Our next speaker is Dr. Professor T. Sundararaman. A physician by practice, he shifted to working in health systems and health policy, heading first State Health Resource Center in Chhattisgarh and then the NHSRC in Delhi. His major contributions being design and implementation of India's National Rural Health Mission and ASHA, the nationwide community health worker program. Over to you, sir, to share your thoughts.
Honorable Minister, all the dignitaries on the dais, front row where I see a lot of my colleagues with whom I have worked in different times on different issues, and a whole lot of young friends who are listening in and with whom I would like to share. I am a student of Kerala, the Kerala healthcare model. I come here to learn. I get myself invited, not for these meetings, but to visit the field. Even now, I've been trying to get Jamila to get some opportunity, some review by which I can wander into the districts of Kerala. I see some things presented here, but I see a lot of interesting things when I go to the field, which over here you take for normal, but because I see different states, different activities, I wonder that how you guys have solved this problem which we are struggling with. You've just solved it. You don't call it an innovation. You just meet the problem and solved it. So I say that I am a student of Kerala. What do I come here and tell you about what to go? I remember, it reminds me of one favorite quotation of Gautama Buddha to me. Buddha's many favorite quotable quotations is, if we are facing in the right direction, if we are facing in the right direction, all we have to do is keep on walking. You are on a path, you have taken a choice. It has led you, as Dr. Srinath was pointing out, into an appreciable, one of the most leading healthcare systems designs, and you have also a social determinants that supports that walk. One needs to walk that path. One needs to walk it with great determination. You know, from a long time in public health, we do something, and I think some people popularized it, called the Preston curve. In the Preston curve, in the x-axis, they point to GDP per capita, and in the y-axis, life expectancy. A lot of problems, technical problems with that curve, especially the use of GDP for wealth and the life expectancy for health. But if we overlook all of that, it broadly means the wealthier a society is, the healthier the society is. But when you actually plot the nations on the curve, and you can do that for the states of India, you will see that according to the wealth of Kerala, according to its GDP capita, you expect a certain health outcome, and Kerala punches well above its weight. So it's an outlier. It will be much higher than what you expect from the degree of wealth it has. Which there has been an interesting discussion on, that this is only a two-way relationship. It is not a causative relationship. The cause can work the other way also. In countries like Thailand, Sri Lanka, Costa Rica, Cuba, Kerala over here as a province, it's worked the other way. Wealthier, healthier situations, health was achieved earlier, and that has been a great contribution to making the state productively much more. So in fact, healthier is wealthier. Healthier becomes a substrate for economic growth, for productivity, for development, for achievement. And you can actually see this if you have seen this graph over the times, that the per capita position of Kerala has continued to grow till no longer it's on average or below average. It's now one of the leading per capita issues. So for a long time, Kerala's health system has been driving even overall economic growth over here. One question that comes to our mind is, at this time, everywhere across, the challenges of introducing right to health care as a right, as a judicial right. And whenever, because I come from the people's movement, my lifetime is a lifetime of championing that concept. Wherever I go, that's what I do. Everyone would ask me, what do you say about Kerala? Has Kerala got a right to health act? Right to a health care act? It's not an easy answer. In Tamil Nadu, which has the same situation, they keep asking me, the officers there, the IAS officers with whom I work quite a bit, they keep asking me, look, we are doing everything that is required to be done. Why are you asking us to put a law that will only create more problems for us? We become more, there will be all sorts of judicial interventions, there will be bringing it into power. And moreover, the central problem is that we have a very weak federal structure, we have a very strong over-centralizing trend, and at such a context, how feasible is it to move to a right to health care? And what is, the simple question is, what is the advantage that that will bring us when we are already on a universal health coverage pathway? This is a question that needs a lot of thought, and Kerala can definitely set an example. My own answer is yes, there is space for it, but while understanding that the political call is a very complex call, we are working in a neoliberal state economic framework, national economic framework, and we are working within a highly centralizing state where the fiscal federalism is extremely weak. How do we actually make it a guarantee? Because the difference is that what you are doing in many places now, it becomes an entitlement. One way of looking at addressing this problem is, whereas the de jure, what by law you do proceeds at one level, de facto we can try to achieve all that is required to guarantee this as an entitlement. Which means precisely what? That the registration in the primary health care becomes an entitlement not only to a comprehensive package of healthcare services, which is where you are approaching, but it also becomes the portal of entry to the entire range of services guided and by need. And this particular problematic has been solved very well in some of the countries of the world. And we are talking of economic and political systems very similar to Kerala situation and the political will. We're not talking of socialist countries like Cuba. That's a different scenario on that. And some of the things that will actually give is this notion of entitlement. Why is Kerala particularly well placed in this is some of your recent achievements, and I must point out even in the last 3 to 5 years, because since my last visit with 2020, when we made a joint presentation to the then minister, that presentation was all about your problems. It wasn't anything about your strengths. But if we made that, I was wanting to see what else had happened in this interim, because 2020 is long back and it is pre-COVID. Pre-COVID is another era in public health. So I therefore did one thing. We looked at it. One is your Public Health Act. I am really happy that you have innovated and built on an old act, but you have added into it the whole dimensions of non-communicable disease. You have added to it. So the usual problem with our act is that it makes the citizen accountable to the state, not the state accountable to the citizen. You somewhat forwarded it by using it to strengthen decentralization, empower local bodies, and make it much more accountable. I think that there is a lesson in the way you have dealt with the Public Health Act that needs to be taken. You have a time? Mike, huh? Okay. The second, what I really feel, and that Dr. Srinath has already mentioned, is the quality of community engagement, the quality of community ownership over the program. Panchayat members, when you go generally on an official visit, you have to get a lot of effort to bring Panchayat members there. Here they are waiting for you. They have things to say. They have things to show off. They want to they are proud of their achievement. There is such an ownership. They want to show what they have added on it. And that, I think, is a huge strength. Because it also means a huge amount of resource mobilization that you are able to do not only through the government but leveraging social welfare measures across things and gain an intersectoral convergence that is enviable. A third major area is all the sub-center upgradation, which you are engaged with. This is more a recent phenomena. I was really worried last time that when you expand the package of services from few selective RCH and immunization to the whole range of non-communicable disease, you can't expect to do it with the same population ratio as before, when one PHC covered 26 to 30,000 population. You will need, because the work per unit is more, you will need more units to do the work. And this upgradation of sub-centers and being able to provide the necessary infrastructure so that actually they are able to work at that is one important achievement of this time. I think that we really need to go. It builds on the Adram program and the earlier situation that has actually upgraded these. I think there is a number of areas which I think I am very happy with. But I still think there are certain areas in which if you are going to be obsessive about achieving de facto a universal health care, which is also an entitlement in health care, there are a few technical areas where I think there is a major scope and a need which has arisen. One, of course, is the registration of deaths and a much greater use of routine monitoring of deaths for driving and informing programs. Preventable mortality before the age of 70 has become a big issue, and the way it is calculated globally and nationally using extrapolations from assumptions, which are assumptions or assumptions, is not the way to go. You have a database, you have an enviable degree of coverage. I am not confusing it with the medical cause of death program, which is also a good program, but at some point it is not on scale. But there is a way. But the other thing which has become a new challenge is the lack of surveys. Before we had the census, which has gone missing. Before you had a reliability of National Family Health Survey, which is under such political pressure that I doubt whether it will retain its character. And before you had the NSSO surveys, the 71st, the 73rd, the consumption expenditure surveys. For whatever reason, this has become missing. This is a great loss to democracy. This is a great loss to public planning. The census is the basic database on which all surveys are planned. And somewhere Kerala will have to come up with some solutions. Otherwise, you will not even be able to project your achievement. The way in which achievement is now getting measured at the central level leaves me very worried. Because all of them are going to go on extrapolated models from assumptions, and you have nowhere, you have the data, you must make it speak. And at one level of making it speak necessarily involves opening those data sets to scrutiny by the academic community and the public health community. It's a risk. People will use it to attack Kerala. But as the earlier speaker told about the many, Dr. Srimati teacher told about the many bold initiatives taken, you must take that risk at some point, because you have actually nowhere else. Like in COVID, your deaths were reported were higher. That was not because others had less deaths. It was because their reporting system was weaker. I think that you, okay. The third thing I would really say is a number of your programs, for example, on pilots for making it comprehensive, SWAS and the mental health program. I don't get the Kerala name. Aswasa. Some of them are brilliant. We actually looked at SWAS model in the Health Technology Assessment Committee, which I chair. Biju actually presented it over there. I thought that it was a great program, and we actually showed that it was cost effective, will reduce costs, but it's not yet taken up to scale. The issue is that many of your good pilot initiatives have shown COPD, no other state in the country is able to address it, and it is one of the leading causes of death everywhere, including in Kerala. But you have actually managed to do a model, but that model is not known, not taken up to scale. And this is what I meant by my original thing, that you must have the confidence to walk the road, that the direction you have taken, because you may get a bit lonely out there. There are not too many people who are going to walk that road, and you may get that. And finally, let me close with one more concern that gets underplayed. I saw that somewhere in the discussion when you're talking of pooling risk pool. I think we must make a lot more of the ESI program and the overall framework of social protection, of how we can extend it to the entire area of unorganized workers. And it is possible to do so, it is feasible to do so, it is desirable to do so. Remember, the ESI nationally, in a place where all of us are struggling for funds, has a 1 lakh crore surplus fund, which it doesn't quite manage to spend. If you think that is an ESI oddity, remember even in Germany, which acts on a social insurance model, they have a 20 billion euro surplus fund. The ESI approach of being able to expand your risk pool and how you will merge it with the public health system may offer you, in a state where federalism, fiscal federalism is a challenge, alternative ways of being able to look at the financing issues. There are many more issues, but basically I think that these are paths that only you and Tamil Nadu to some extent, I've just come out with making the recommendations. You know, this was my reply to the officers over there as to why you need a right to health care and how you approach it. This is written for Tamil Nadu, not for you. But similarly, I think you need to work out a blueprint. Whenever the political movement is right, you can use the judicial option. But till then, I think we need to have a clarity that that is the direction that we are walk on, and the confidence to walk on that direction. Thank you.
Thank you, sir. For the students of public health in Kerala, you have reconfirmed that we are on the right track. Thank you very much.